All right, welcome to Deuk Spine Institute live stream spine surgery. I'm Dr. Deuk Majan, one of the founders. I'm here with a patient who has had a fusion done, and above the fusion at L2-3 there's now the disc is worn out and bulging out. We call it adjacent segment disease. So we're going to go in, we're going to repair that disc, because doing another fusion is just not a good option. This patient has high risk for comorbidities, and basically having a fusion surgery in his condition is just too risky. So we're going to try a less invasive surgery, which I think will work quite well. It's called Deuk laser disc repair. It addresses the same problems that a fusion would address. And the primary problem here is pinched nerves causing spinal stenosis. Pinching it as herniated disc, pinching the nerves causing spinal stenosis. Shot. All right, so you can see he's got a fracture as well at L1. Show us that, Jordan. You guys see the bone is crushed down like a little aluminum can. That's old. We're not treating that. Nothing to do with why we're here today. All right, you're doing fine. Just lay still for me, okay? You're doing great. Nope, not at all. He's perfect. Yeah. Shot. All right, so I want to get to the facet joint, which is right there. Show us the facet joint. Full of arthritis, by the way. And that's, well, yeah, that whole area. And show us the facet joint above. Look at the difference. To the left. Yeah. That versus the one below, which is much bigger, more sclerotic. So why is it so sclerotic? Because it's been damaged, and now the bones are rubbing on each other, kind of building up more bone. It's your body's response. Shot. Just, you're doing great. Shot. You don't need to medicate him anymore for me. You do what you feel is safe. Shot. For him. Shot. All right, let's get an AP. We're entering the neuroforamen on the both sides. We're going to go transforaminal with our approach. Transforaminal means, trans means across or through. Foraminal means through the foramen. The foramen we're referring to is the neuroforamen. Yep. The neuroforamen is a natural opening on the side of the spine where the nerves come out. Shot. And we're going to go just next to the nerve. Shot. To get to the herniation. Shot. You're doing great. Shot. All right, so I'm just literally up against the back of the vertebral body. But this guy, on the other hand, is too high. We're going to take it out, and I'm going to try a lower starting point. Shot. Not bad. Shot. Shot. I'm using the X-ray to guide me. It's called image guidance. Shot. AP. Quick. All right. Any questions, Henry?
Yes, we have a question from Mixin on Up on YouTube.
Okay, great.
Asking, is the patient awake?
Patient is awake, but also asleep. It's kind of like when you're a little baby falling asleep and your mommy was whispering in your ear. You're not really awake. You're not in a coma, but you're asleep. Yeah. So we don't have levels of consciousness as clear as awake, okay? But they're not intubated and they're not on a machine. But they're sedated through an IV sedation. Shot? And I have no idea whether they're awake or not. But I talk to my patients as if they were. Because if they are and they can hear me and I say something to explain what's going on because they're awake, that's a lot better than just pretending they're asleep when they're not. So I err on the side of caution. AP, that they could be awake. We're in on the left side. I think we're close to being in on the right. Shot? Just want to be a little more lateral. Shot? Shot? We're in. Okay, we're in. On both sides, we are going to do a discogram, but not evocative. Our patient needs to stay asleep, but I do want to do my discogram. Shot? All right, so we are definitely inside the disc. You can tell there's a lot of scar tissue in the back because the dye is going forward, not backwards. And that means that there's a lot of inflammation. What would cause that? Well, herniation. Herniation causes inflammation. You can't get inflammation without it, not in the disc. Must have herniation. So it's an indirect sign there's a problem. We're going to bring our needle out and advance our dilator under X-ray supervision. The dilator has a tapered tip. Again, this patient had a fusion. He did fine with it for a while, but eventually developed adjacent segment disease above the fusion. I just think some of these are, just want to make sure I have lots of them. Shot? I think I'm not going through the center hole.
Oh, you.
Look at that. Look. Right?
Yeah.
Oh. Shot? All right, so I had to correct something there. I was running the dilator down on the side hole, which is for injecting medicine. It's not the end of the world, but it does make it more challenging to get down. So I just adjusted that. First of all, I diagnosed the problem, and then I made the correction. Any questions? Shot?
Yes, we have a question from Lanu on
Hello,
YouTube.
Lanu. I can feel the herniation right now. Shot?
They asked a non-medical question. Do you have gatherings for your staff, like summer picnics or movie gatherings?
We do. Yeah, we actually do, Lanu. We have a lot of nice gatherings. We just had one. What was it, Christmas?
Yeah, Christmas. Yeah.
We usually do a summer. Is that it, Jordan? In already. Shot? All right.
Yes.
we'll do a picnic often in the summertime. So yes, we like doing gatherings for the staff. But the truth is, it's really hard to get them to go to these gatherings because they all like working so much, they never want to leave work. And they get angry with me when I schedule non-work related activities. Right, guys?
Of course.
Who wants to go out and have fun? See, nobody said yes. Who wants to stay here and work?
Me.
There we go. The voice of reason, the voice of reason. No, but the reason why that my staff don't like to go away from work is because work is so much fun. I mean, imagine if you got to work with patients every day that you're fixing their life, getting rid of the pain they've had for 20, 30, 40 years. That's a special time in a patient's life. You know, my father was an OBGYN, and he would deliver babies back in the 70s, 60s, 70s, 80s. And he always told me that, oh, look at that herniation right there, guys. We got a giant one. He always told me that OBGYN was the best specialty in medicine because you were with, all right, never mind. We don't have that's about a centimeter or so long, okay? You guys see it, Henry?
Yes, we do.
We're going to get a few more like that, don't worry. Whew. But he said it was the best time of people's lives because when they have a baby, that's like their happiest moment, right? And for me, my dad delivered ladies' babies, so, you know, when you have a baby, you're carrying that thing around for 9 months, right? And that baby changes your life forever. But from the moment you're trying to conceive to the time that you deliver the baby, you know, it can be a year, let's say, and as that baby is growing in you, you undergo these physiological changes, weight gain and discomfort. Thank you. What's going on over there with the laser? Huh? Would you just forget to turn it on? It wasn't on a minute ago. I'm trying to figure out, do I need to have all my lasers serviced and spend a lot of money? Or do we just have a human error where we forgot to turn it on? All right. I'll let Luis figure that one out. So, to be able to take a patient who's had pain every day of their life and deliver them from that suffering. Oh, look at that. What do we have here, guys? That's the needle on the other side. See that?
Yes, we do.
So we don't want to hit it with a laser, otherwise we'll melt it. And then it'll fuse. And we won't be able to get the guide wire in. So you just got to be aware. If you're doing surgery and you have bilateral needles in a disc, you just want to be aware of that. So you don't melt the needle on the other side while you're operating on this side. I've done that before, by the way. I learned from experience. We actually got one needle stuck where we couldn't get the stylet out and couldn't do the surgery, and we had to replace it. So that, it set us back about 5-10 minutes, but it was an unnecessary setback. If I had been more careful, I would have avoided it. Any questions from our audience?
Yes, we have a question from Mixin' On Up once more on YouTube asking, how many surgeries do you do in a typical work week? In fixing the most outrageous pain I've ever encountered, bless all of you.
Oh, thank you. You know, honestly, it's hit or miss how many surgeries I do a week. I don't know if you realize it, but we're a very small company, and we should be doing, you know, $1 million a year, but we could never handle $1 million a year. But that's how many people need this service. Believe it or not, the incidence and prevalence of chronic back pain is very high. And but we probably do 10 a week to maybe, on a really busy week, 15 of these surgeries. And yeah, we love it. Every patient, we can get rid of their pain and improve their quality of life permanently. We're very happy to do that. That's why we're here. Did I get all the questions?
I believe so. Yes, you did.
All right, you can see with this patient's disc, a lot of yellow coloration. That's heavily calcified, old, scarred up herniation. And what that means is this has been here a really long time and gotten a lot of inflammation. So there's the needle right there once again. You guys see the needle?
Yes, we do.
I'm going to avoid it with my laser. By the way, for those of you who have watched for a long time, you know that I actually hit my own finger once with the laser. Early on when I started using it, I was a bit aggressive with twisting it around, and I snapped it right where my finger is. And the pedal was on at the time, and it shot a laser pulse right into my finger. One pulse before it hit my brain what was happening, and I stopped the pedal. But it literally almost went through my entire finger. One pulse of laser energy. I still have the scar today. If you look at my fingerprint of my right index finger, you will see a laser blast mark. It's scarred there forever. So yeah, I made a few mistakes over the years and learned from them so I don't repeat them. I could tell you that was one of the most painful experiences of my life. That laser is extremely painful. All right, any other questions?
Yes, we have about 2 questions. This next one coming from Lanu once more on YouTube, asking, Rita followed you very closely. Is she a former patient?
Well, first of all, I can't talk about any former patients at all because it's a violation of doctor-patient, confidentiality. But I will say, I'll just leave it at that, actually.
Next question coming up from Mixin' On Up once more on YouTube, asking, is the compressed nerve above or below where you are working right now?
Oh, it's a great question. Yeah, great question. So we are at the L2-3 disc, and there's 2 nerves that are being involved here. One of them is right over here on the left side at 9 o'clock, and one of them is at 12 o'clock. So 12 o'clock, 9 o'clock. The 9 o'clock nerve is called the exiting nerve, and I might be able to show that to you in a minute. The 12 o'clock nerve is called the traversing nerve. And so the exiting nerve at L2, it's L2-3, right? Yes, sir. The exiting nerve is L2, the traversing nerve is L3, because we're at the L2-3 disc. So you won't be able to see the L3 nerve, but we're going to be decompressing it nonetheless. So when you ask which is affected, they're both affected in this case. But typically it's going to be the traversing nerve, which is the one at 12 o'clock. This is all scar tissue from chronic inflammation due to the herniation. And the laser is truly the safest and most effective way of removing it. We're getting to that spot. Right here is where a lot of the pressure on the nerve comes. I apologize for the overexposed image. We could probably turn the exposure down 1 click. Yeah, I think that helped. Or the lighting, I should say. All right, the laser fiber, for those of you who don't know, is the glass fiber at 12 o'clock. The blue stuff is just plastic around it as a protective insulator. And that laser fiber is 1 millimeter. So just to give you an idea of how big things are down here. Henry,
Yes, sir.
why don't you run the video to show our audience why do we do the one on why do discs cause so much pain?
Not yet.
Let's
We'll-
do that one.
Copy that.
And then we can do the 30 causes of back pain.
Copy that.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals.
Okay, great. So you can see that discs injuries cause pain because they elicit or promote inflammation in the back of the disc, and that's what you feel as pain. Over time, they can actually get larger and compress on nerves. All right, we're almost done with this left side at L2-3. And by the way, as soon as I'm done fixing these two sides, I'm going to be doing a Deuk plasma rhizotomy to get rid of facet pain. Because he has both disc pain and facet pain and pinched nerves. Any other questions?
No current questions.
Let's show the audience how the Deuk laser disc repair works, and then we'll talk about the 30 causes of chronic back pain.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
That's all right. Welcome back. We are working up near the L2 nerve root at this point, and I'll show you what I can in a moment, but there's a lot of scar tissue here. And look at all this stuff. It's super thick. This is what's been pinching his nerves.
We have a question
Sure.
coming from Mixing On Up once more on YouTube, asking, so the tube your laser goes down is essentially protecting the nerve from your laser?
Yes. Mixing on up is pretty smart. That's exactly right. The tube that goes in over the dilator and the tube we use for this scope is protecting the nerves. The nerves are just outside the tube. You're correct. That's why it's called a tubular retractor. It retracts the nerves out of the way. Pretty standard principle for surgery, but I didn't develop the tube. It was the idea was by Dr. Parvis Camben here. He was an orthopedic surgeon in the United States. He's the one who thought of it. Can't take credit for that, but pretty ingenious discovery.
We have another question
Sure.
coming from Saul on YouTube,
Hello, Saul.
saying hello
Welcome.
from Puerto Rico,
Hi there.
asking how long is your waiting list?
It's a great question, Saul. So the way it works, Saul, just so you understand, is number one, we want to meet you and see your MRI and make a diagnosis, what's wrong with you, all the things we can. And we like to do that with a virtual review. So you can stay in Puerto Rico or wherever you want to be, and we'll do a 10-minute review and see what's wrong and if you're a candidate for one of our treatments, which you probably will be. Then, once we know what's wrong, you get scheduled for surgery if you want to be scheduled. And that waiting list, I don't control it. It's controlled by our scheduling team. And they would tell you exactly when we can do your surgery. It depends on several factors, but one of them is your medical condition. Are you healthy? Do you need to undergo extensive diagnostic testing by a cardiologist? But assuming you're healthy, like most people are, then we can usually get you in for surgery within a week or two. We don't like to make people wait for surgery. We like to get it done quickly. Nobody should have to suffer in pain. All right, let me take a look at the nerve over here. Oh, there's still herniation there. See that? Wow, interesting. That's a foraminal herniation. That is ugly. May have to use a laser on that one. Thank you. All right, let's get the laser in.
We have another question.
This was sitting right on his nerve. Poor man. Yeah.
This is coming from Tracy on Facebook, asking, can you please explain to your audience why you do not advocate the full removal of the piriformis muscle? Thank you.
Why I could not advocate full removal of piriformis muscle?
Correct.
Yeah, because it's unnecessary. It's dangerous. It's high risk. There's no reason to remove the full piriformis muscle. There's no benefit to the patient to do it. So, yeah, that's what I would say. All right. I think we're done here on the left side. Let me see if there's anything else I can do. So, we're looking in the foramen. There is some fat and scar tissue here, but I'm not here to remove fat and scar tissue. I'm here to remove the herniation. So we're gonna leave that part alone. Why is the suction not working here?
Please.
Okay. Got to do the basics right, okay?
Light off of the scope, please.
This is a little bit too dark. Lay still. He's fine. Just moving a little bit. All right, next question.
At this moment, no current questions.
So we've completed the left L2-3 disc repair, removing probably 60% of the herniation is my guess. We don't ever get 100. I tell patients, don't judge based on what the MRI looks at, like judge based on how you feel. And the truth is that no surgery in the world can get all the herniation out. So what we want to do is remove the part of the herniation causing symptoms. So this is more of a strategic type surgery, all right, not a structural type surgery. Knife? Oh, I did? In other words, we're going for an effect on a very small area rather than a big area. That's what minimally invasive surgery is about. It's about doing things as minimal as possible to avoid unnecessary things. Like, for example, taking the whole piriformis muscle out. That would not be minimally invasive. That would be maximally invasive and totally unnecessary. Think ninja. We want to be like spine ninjas, crawling around, fixing things without you even knowing we're there. You know, getting the results we want without the damage to your spine or body we don't want. All right, shot. You can see I'm making my way in to the next disc. How's he doing? Shot? So one thing this particular method does that I really liked when I learned it, it's called the inside out technique from Dr. Young, is you start inside the deepest part of the herniation. And what you're doing is you're actually going through the outer part to get to the inner part, and you're pushing the outer part back in. So you're removing the herniation from inside the tear rather than removing the herniation from inside the foramen where the nerve is. So it's safer for the patient. We've cold welded the dilator to the tube. What that means is there's some material stuck, like disc material stuck between this dilator and the inside of the tube. You see that?
Yes,
Stuff
we do.
right there? That disc material creates a, come on, you know, I'm over here working. Please don't put things by my feet. The material stuck between the two pieces of metal wedge them together and make them move as one. We don't want that. We want them sliding and moving individually. Okay, any questions?
Yes, this next question coming from Mixin on Up once more on YouTube, asking less scar tissue with minimal invasive too, right? Scar tissue played a big part that led to my second discectomy.
Yes, mix up too. There is no scar tissue with this surgery. Scar tissue comes from collateral damage from the surgeon during their surgery. In other words, damaging muscle, damaging ligaments, damaging tissues, causing bleeding. Because we don't have any tissue damage to your body except your skin, we make an incision. There is no scar tissue. The annulus will heal with collagen, but the rest of the tissues aren't going to scar because we're not damaging them. What is the issue? Yeah. So we don't have bleeding, we don't have collateral damage, we don't have scar tissue. And by the way, the patients with this surgery, they don't take pain meds afterwards. for the surgery because there's no real pain. Our patients, the reason why patients take pain meds after spine surgery is the surgeon has destroyed normal parts of their spine. And by doing so, it's created swelling and pain that requires narcotics. We did a study, as a matter of fact, Arius Deuk and I did a study showing that patients who had the Deuk laser disc repair procedure took basically no narcotics, far less narcotic painkillers than those patients who had fusion. All right. Fortunately, the pieces of herniation here are big and chunky, and they're going to be a pain in the ass to get out. God damn it. Fucking time-wasting thing. Oh, yeah. Our other patients we've done today have done phenomenally well. Our first patient was from Trinidad.
You have to connect it. Go now, go to the floor and connect it. Yep. 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 Yep.
All right. Guys, why are we leaving things like that off?
It just looks like when we move the machine or something, the X-ray, and then we get disconnected.
So, but we don't need to open a fresh one. That's not really sterile down there. All right, any questions, Henry?
Yes, we have a question from Michael on YouTube.
Hi, Michael. Sorry about the poor quality of visibility here. It's coming from bleeding. It's just a little bit of bleeding, but a little bit of blood endoscopically will really affect the view. And that's why we're having a fogginess, is blood from the other side that we've already fixed coming across the inside of the disc to get to this side. There's one of those pieces of herniation I was talking about that we shove them in and then fish them out. Much better than fishing them out of the foramen. Go ahead.
Question from Michael on YouTube asking, could the DLDR be used as an alternative treatment to this patient's fusion?
Yes. Yes, the DLDR could be used as an alternative treatment to fusion. We're not doing a fusion, obviously. This patient's had a fusion in the past. And for me to say if the DLDR could be an alternative to fusion, I need to see a patient's MRI to be able to make that determination. Obviously before they have the fusion. But yes, that's the whole point. The DLDR treats the same problems fusion does. Fusion treats instability, DLDR treats instability. Fusion is used as part of a treatment plan that involves decompression and stabilization. DLDR does the same. So the DLDR does it better. As a surgeon who does both, fusion and DLDR, I could tell you 98% of the patients I've done fusion on could have had the DLDR. And we've offered it to them, but some people choose not to have it, usually for insurance reasons. Other people choose to have the DLDR. So I think if insurance and money wasn't an issue, everybody would have this procedure rather than a fusion. The recovery is 1 hour. This patient's going to go home. It's safer. With fusion, you have general anesthesia. do general anesthesia. Right, Dr. Berndes?
Yeah.
You know, a lot of people can't have fusion because they can't do general anesthesia. General anesthesia requires a tube, a ventilator. Basically, you're on life support, you know, for a few hours and sometimes longer. All right, I don't see any more pinching of nerve. That looks pretty darn good. I think we're done with this one. Okay. We're going to do his facets next. I got some chunks in there I got to irrigate out. I need some good amount of irrigation. Great question.
We have another question
I'll take it.
coming from Sue on Facebook,
Hi, Sue.
asking what is the total number of DLDRs you have done now?
Well, Sue, I'll be honest. I stopped counting at 2,000. I think Sanjay is working on a having this app on our website, the new website being launched, that will keep track of our DLDRs going forward. So we'll have a running live total and other data points that will be interesting as well. I'm going to staple up his incision. We put 2 staples usually. That's it. And then a Band-Aid. And we'll get the staples out tomorrow morning when they come in for a visit. Next, I'm going to be doing his Deuk plasma rhizotomy for the facets. We've treated the disc. Now the facets need treatment. And the facet joints were really hurting him a lot. They were causing him to hunch forward because it hurt so bad for him to stand up. Shot. All right. So I can see my target there. I'm literally right on target. However, the one below I cannot see. So we may have to play with the fluoro a little bit. So the Deuk plasma rhizotomy, we use a probe that basically burns the pain nerve to the facet joint. Shot. All right, so you can see my target is just below where I'm at. I could feel it. Hold on. Shot. Yep, I'm right on it. That's the transverse process. All right, now that's better. Shot. I had to poke through the fascia. Oh, it's a perfect spot. Exactly where my probe is. You guys see that? Junction of the transverse process, superior articular process, and the pedicle. There's the absolute perfect spot for facet. DPR. All right, now we want to get the one below. That's the hard one. I don't really see that transverse process. I'm going to leave this thing where it is. Shot. You're going to have to rotate that floor or pull it towards you. Shot. Pull it towards you. Did you pull the whole base towards you? Yeah, shot. There is the TP. I think I see it down there. And what's obscuring it and confusing the situation, not for me, but maybe for you guys, is this gigantic osteophyte coming off of the, yeah, that's it. I'm sitting literally on top of the TP. I need to go a little more medial. Yep. There's the osteophyte. Looks like a bird's beak. Shot. The TP is right where I'm at. I'm in the perfect spot right there. And that's where I need to burn. So a lot of experience on my part, you know, doing surgery and knowing exactly where to go. That makes the surgery easier. But we're in exactly the right spot. And I think he's going to have a really good result. All right, so one side done. We're going to do the other side next. I got it. Shot. That looks pretty damn good. All right. Num num here.
I
Oh, you already did?
Yeah.
Now, this is an outpatient surgery. He's going to go home in an hour or less. That's how quick the recovery is. Unlike fusion, where you go home, you know, at Duke Spine, we send our patients home pretty quick, but at the hospital, they're going to keep you there overnight. Shot? Or even a few days. Shot? All right, I'm too lateral. Show us where I need to be, exactly. Shot? So I'm moving my probe over there. Shot? Uh-huh. Shot? Shot? $30. Shot? Oh yeah, that's really nice. All right, we're done. That is a rhizotomy, folks, for the facet joints. Good job, Luis. And it's done with the Duke Spine way. We pioneered it here. It actually really destroys the pain nerve. I know people don't like hearing that the nerve is being cut and destroyed, but it's not the nerve root, it's the actual nerve to the facet joint. It's supposed to be cut and destroyed in this procedure, but an RFA doesn't do it. This procedure does. We've had tremendous success getting rid of people's pain permanently with it, and it's going to be the future treatment for facet pain, SI joint pain, knee pain, hip pain, shoulder pain. Pretty much all joint pain will be the Duke plasma rhizotomy. All right, any questions, Henry?
No current questions.
You can wrap it up.
Yes, sir.
One more surgery to go.